So, yeah, I drew it very crudely, but it doesn't matter, but I just changed the words off of that diagram that was maybe causing some confusions because the words that they use are not the same that I use all the time. So we can just redraw it. I did it very crudely. Remember, your nose is in the middle, so that's medial or nasal. It's the same thing. And then you have your laterals. So we'll just label that real fast.
105.
Yeah, it's not that far. Remember, we have lateral, medial, and medial. So the vision that comes in on your left eye, well, we're flipped. So left eye, lateral field goes where? Medial on the same side. So lateral vision comes in, and it's going to hit on the medial side of the retina. So remember, field of vision is going to be opposite than the retinal field because images are flipped and reversed. And the same thing is going to happen on the other side. I'll change that to blue. Lateral vision on the right goes into the eye and hits the medial portion. Now, the medial field of vision, so your tunnel vision, everything straight down in front of you, that does change. It goes to the opposite eye as well. So the medial on the right goes where? This one right here. The left, lateral. Okay, and then it's the opposite for the other one. Medial vision hits the retina. So now we are in the eye, we're at the back of the retina. We are converging all of these into a single nerve. And which nerve are we going to converge into? Optic nerve. So I got green. And where does this nasal one go? Right here. Does it stay on its side or does it cross over? The medial retina view. This crosses into the optic chiasm. Okay. Okay. And then this one, you're still dealing with our left field of vision. This one right there, where does that one go? It goes straight down, and what is that little circle there called? Yep, lateral geniculate nucleus, and then what structure is that a part of? Thalamus. Remember, all sensory has to go through the thalamus. Okay, so this goes here, this goes here as well. Okay, and it's just the opposite for the other eye. The medial retina goes through the optic chiasm into the lateral geniculate nucleus, and this one comes down as well. And this structure in the middle, where they cross, it's called what? Okay, the optic chiasm. We know these are the LGNs. Lateral geniculate nucleus. And finally, the last little bit that happens, we have to get it to the back of the brain, and that area is called the what? Primary visual cortex. What lobe is it located? Yep. Okay. So all the greens go there, and then all the blues from the LGN here go there. And that is our visual pathways. Everyone better on it? There will be one question on it, I'll tell you that. There's one question for physio on this, just one. So if you want to just sacrifice a question and just be like, I'm done, move on. I will say though, for PA, you will get this a lot more in ophthalmology, in neuro with me next winter, because we go through like different visual problems. You have to know what type of vision loss they have, where is it in that pathway, and you can figure it all out. So anyway, everyone good on visual pathways? Okay. So let's finish up our neurology. Okay. So we're going to talk more about the autonomic nervous system for a little bit. Remember, our nervous system is broken up into two classifications. We have the autonomic nervous system and the somatic, which is all the body or voluntary functions. Autonomic nervous system controls everything else. That does it automatically, so we don't have to think about it. Again, carries out conscious without being aware. Maintenance of homeostasis, remember that's the most important thing. As we go through each unit, I'm going to tell you what is the main homeostatic variable that they're all worried about. The cardiovascular system. The only thing the cardiovascular system cares about is your cardiac output. That is the homeostatic variable for cardiac. Everything we learn, blood pressure, heart rate, are just ways to alter cardiac output to keep it normal. And you'll see when we go through that in a couple weeks, everything that goes on with cardiac. The other thing it does, stress response and your visceral response, or just rest and digest. So we have our parasympathetic and our sympathetic nervous system. Which one is always dominating? Parasympathetic. Remember, we want the control mechanism to be the dominant one. The parasympathetic is the control. Rest and digest. Keep everything relaxed and easy. Stress response, fight or flight. The problem with stress is that if it goes on for too long, you start getting problems, mainly with cortisol, which we'll talk about a little bit today as well. Okay, so we talked about parasympathetic, sympathetic, and the enteric, which we'll deal more when we get to GI. There's also, obviously, integration with the endocrine system because the hypothalamus is there. This hypothalamus, also remember, is outside that blood-brain barrier, so it has a way to like taste the blood and see what's going on and make changes regarding hormonal status. And again, they oppose each other, but the parasympathetic is the dominant. So when you're thinking and you're studying sympathetic versus parasympathetic, don't go crazy in the weeds and try and memorize every single line. Just think about it from a generic perspective. Fight or flight, sympathetic. I need to run away from something. I need to fight. Cocaine bear is coming, we gotta run. So cardiovascular system, heart rate and contractility increases. I need more blood supply to do everything I'm gonna be doing, so the heart rate better go up, cardiac output better go up. Blood is redistributed to the muscles, heart and brain. Okay, we want that blood to get to our muscles because our muscles are going to need a lot of oxygen, glucose, so that we can have fuel to do whatever we got to do. We don't want the blood going to your stomach to digest and absorb your food. We don't need it. We're in a fight or flight response. So we need to shunt the blood away from the GI system, put it into the muscles. When we get to the cardiovascular system, we'll go about how we do all that. Tissue metabolism. We need to increase our metabolism. We need to get all the energy resources ready to go. So we get glycogenolysis. What's that? Breakdown of what? Glycogen into what? Glucose that our body needs for energy. Lipolysis of our adipose tissue gives us free fatty acids. Again, energy sources. We need immediate energy sources to fuel whatever we're running away from. So again, just think about it this way. Anything that's going to increase metabolism, blood flow, these are all sympathetic responses. Smooth muscle, We get contraction of the sphincters of the GI and urinary tracts. You don't want to stop and pee if you're trying to run away from a bear. So you're going to shut all that stuff off so that you don't have to stop. And dilation of the bronchioles and pupils. Why do we want dilation of your bronchioles? More air exchange. We need more air. We need to get more oxygen in. Let's get those wide open. Pupils. We talked about yesterday. We need more light to come in so you can see everything. What muscle is under the sympathetic control to control your pupillary response? Radial muscle. That's under sympathetic response. What is under parasympathetic response? Circular. And what does that do? Constriction. Okay, very good. Parasympathetic activation, again, conserve energy, conserve resources, digestion, and all that stuff. So heart rate goes down, GI function is increased because now we have the time we can spend to digest our food. So that's the parasympathetic, rest and digest, or fight or flight. Just always keep that in your mind when you're studying this stuff. So our sympathetic nervous system, we have what's called sympathetic side chain ganglia, this sympathetic chain of ganglia. You can see it's right here. These are on both sides of the vertebra, so we have two of them going along the side. So we're going to talk about these ganglia. You don't have to study the slide. Don't worry about the slide. It's just there to demonstrate things. So don't worry about memorizing that slide. So our sympathetic nervous system with this sympathetic side chain ganglia, which is right here, when we have a output, so remember, let's look at the nerve again. We have our spinal cord transected there. We have green lines and we have red lines. The green line, which way is that arrow going? Into the spine or out? Into the spine. What goes into the spine? What kind of information? Sensory. So we're not going to deal with the green here because we're not worrying about going into the brain. We're worrying about what's coming out. And what's coming out of the brain is the red one. What is the red line referring to? Motor. That's an output, right? That's an afferent output. It's going away from the brain and spinal cord. That's an afferent output. It's going out to something. So that's why we follow the red line with this diagram. So all we're saying here is that when this sympathetic impulse comes out and it goes into the ganglion, it's got three things it can do. Either it can synapse and at the peripheral ganglion, which is right here, and then it goes wherever it's got to go. It can go up or down that side chain ganglion, which is right here and right there, where it's going up or down. Or it can just pass through and then it goes through to the peripheral ganglion, which is right here. So, yep. So those are the three things. Either it can stay within, go up or down, or pass through, go to the ganglion to stimulate another organ to do whatever it's got to do for that sympathetic response. Another interesting thing we got to know, let me see if it's at this one. Yep. So one thing I want you to know, sympathetic has short preganglionic fibers. So if you look at the red line, leaving the nerve, it goes right to there. That's a very short distance. Let me change colors. This way. Very short distance it's got to travel. So sympathetic has short preganglionic fibers, but long, well, let me change that. Post. So once you have this synapse here, this ganglion, this is going to be a long nerve going wherever it's got to go. Just know sympathetic has a short preganglionic and a long postganglionic. Parasympathetic is just the opposite. They have long preganglionic and short postganglionic. And we'll have a thing to demonstrate that in a few slides to put it all together. Okay. We're still dealing with sympathetic nervous system here, so just keep that in mind. We're just talking about sympathetic. Acetylcholine is the primary preganglionic neurotransmitter. It's going to release acetylcholine, and it's going to bind to a nicotinic receptor. on that postganglionic neuron, and then after that, it's going to be whatever that target tissue is going to release. That's the adrenergic side. Norepinephrine is the primary neurotransmitter released by the postganglionic sympathetic nerve. So the preganglionic secretes ACH onto the postganglionic receptor that is a nicotinic receptor. Then the long postganglionic nerve will release norepinephrine at the postganglionic site, except sweat glands and adrenals, they have something else we'll talk about. So alpha 1, alpha 2, beta 1, 2, and 3, those are the 5 adrenergic receptors. So if you see anything like a beta blocker we give for heart rates, it's going to block the beta receptor. And a beta receptor is what type of receptor? Adrenergic. So what do you think is going to happen if I stimulate the beta receptors? What's going to happen to your heart rate? It's going to go up because it's a sympathetic response. It's an adrenergic receptor. If I stimulate it, the heart rate's going to go up. So if I give someone a beta blocker, I'm going to block that beta receptor, and what happens to their heart rate? It goes down. That's why you have to know these receptors. Understand agonist and antagonist. An agonist is going to stimulate the receptor. An antagonist is going to shut it off. So again, know these definitions, know the words, so that when people are speaking them, you understand what they're talking about. And again, obviously, very important targets for drugs. Okay, the adrenal medulla is the inside of the adrenal gland. The adrenal gland is kind of like a triangle shape, and it has the cortex. And that's the cortex, the adrenal cortex. This is under neural control because sympathetic preganglionic neurons go right into the adrenal medulla, releasing acetylcholine, which stimulates the medullary, the inside, to secrete your epinephrine and norepinephrine. So we said before, except sweat glands and adrenals, because we're talking about the adrenal gland right now. Okay, they help each other out. We'll go through this a lot more when we get to cardiac, so don't worry about epinephrine and norepinephrine for now. Just know they're released from the adrenal medulla from a neural input. Here is our parasympathetic system. The parasympathetic system only has a certain amount of nerves that are parasympathetic nerves. Cranial nerve 3, 7, 9, and 10 are your parasympathetic nerves. We also have S1, S2, and S3. No, S2, 3, 4. 2, 3, and 4. Those are also parasympathetic nerves. S2, S3, S4, you can see where they go to. They go to the bladder, the sphincters. They help keep things, remember, during parasympathetic, we want everything to be relaxed so that we can move and digest. So if you look where the parasympathetic innervations are, it's going to be in areas that it needs to control. In the parasympathetic, you can see here, they have long preganglionic and short post ganglionic. Okay, these are long to get to the ganglion, and then it's a short to get to the rest. So it's just the opposite. So that's our parasympathetic nervous system. So here's that diagram I was telling you before. This is a great diagram that covers the last 5 slides. So we have our parasympathetic. The majority of parasympathetic is going to be from your vagus nerve. That's the dominant of our parasympathetic system, goes via the vagus nerve. So you see parasympathetic, always going to be acetylcholine onto a nicotinic receptor. I'm sorry, muscarinic in the heart and the vessels. So the M is muscarinic. We have long preganglionic fibers, short post. This is still parasympathetic. And then the following 4 are all sympathetics. Okay. Sympathetic adrenergic, heart and your vessels. Sweat glands is an anomaly because it does different things. With their sweat glands are under acetylcholine and muscarinic receptors. It's a sympathetic nerve, but it uses acetylcholine. That's a separate special case with acetylcholine in the sympathetic system. It's the only one that has acetylcholine in that postganglionic area. Everything else is always going to be for sympathetic norepinephrine. You have dopamine here as well. You have dopaminergic. They deal a lot with your renal vessels, which we'll get to when we get to renal. And then finally, you have your adrenal gland, and acetylcholine binds to a nicotinic receptor, which secretes epi and norepi directly into the bloodstream. And that epi and norepi is going to start to activate your alphas and your beta receptors, providing that sympathetic response. Everyone good? If you can understand this graph, it solves the previous 5 slides. So this is a good one to study. So effects on these receptors. It's either going to excite or inhibit. It depends on the tissue type that you are activating. We have ion channels, or these metabotropic receptors, called calcium influx or potassium efflux. G proteins, what do those do again? Amplify the signal coming in. We have cholinergic receptors, only nicotinic and muscarinic. Those are the only 2 cholinergic receptors that we have. Nicotinic is a ligand-gated channel. Muscarinic just is a G protein. You don't have to know that in much detail, but you do have to know that nicotinic and muscarinic are cholinergic. We have our adrenergic receptors, again, your alphas and betas. Norepinephrine is mainly going to bind to alpha receptors. Epinephrine is kind of balanced between alphas and betas. When we get to the cardiovascular, we're going to talk about this a lot and how we alter our blood vessel diameter, how we shunt blood, all that stuff comes with epi and norepi. So we'll deal with all that later on. So here is a chart that talks about the different receptors and what they do. I'll tell you which ones I want you to know. Okay, SA node with a sympathetic response, increased heart rate. It makes sense. Always, when you're studying this chart, just keep in mind, sympathetic, parasympathetic, fight or flight, rest and digest. What does my body need to do right now, depending on what environment I'm in? The receptor type is your beta 1. And under parasympathetic control, your heart rate will decrease because you're in a rest environment and your heart rate comes down. Okay. I also want you to know bronchiolar smooth muscle. You're going to have to know all these eventually anyway, but you can get to that a little later on. Less stuff to study right now. But eventually you're going to know all these anyway because you have to know how these drugs work that you're giving people. Bronchiolar smooth muscle. Sympathetic response causes relaxation. Remember, we want our bronchioles wide open, more air getting in and out. And it attacks beta 2. So, way to remember, beta 1 goes to the heart because there's one heart. Beta 2 goes to the lungs because there's 2 lungs. There's a beta 3, but you can deal with Dr. Wood later on. Don't worry about the beta 3s. So, beta 1, heart, beta 2 is in the lungs. I also want you to know the urinary bladder. Okay, so there's 2 parts here. We have the detrusor and we have the sphincter. What is the detrusor? What did you say in the back? It squeezes the bladder. Detrusor is the muscle that contracts to squeeze the bladder. During a sympathetic response, why does the detrusor muscle relax? It can hold more pee, very good. Just relaxes, it gets bigger, it can hold more volume of urine, which is important during a sympathetic response. But under parasympathetic control, we get contraction of the bladder because we're going to have to pee, we have to get it out, so contraction of the bladder occurs to expel the fluid out. The sphincter control, with sympathetic response, it causes constriction. Okay, remember, we don't want to have to move our bowels or our bladder. So by having that sphincter very tightly controlled, we don't have to think about holding in our bodily functions. Our body will take care of it in that stress response. And during a parasympathetic response, relaxation of the sphincter so that urine can flow freely and out. Okay, and last one is just a pupil. Dilation with sympathetic, again, you know why. Radial muscle, and we get constriction, which is the circular. Make sense? So just keep them that way, always sympathetic, parasympathetic. Know what you have to do during those environments, and just think about the question, which one is going to help me perform activity if it's a sympathetic question? Which one's going to help me digest and relax if it's a parasympathetic question? Okay, so just always keep that in your mind. Integrative and behavioral functions. Now we start getting into a little bit of thought, memory processing, feelings and fears and stuff like that. So 3 areas of the brain we're going to focus on. Major one is the hypothalamus, again, a major control organ, endocrine and your autonomic nervous system. Homeostatic functions occur here. Motivated behaviors. Okay, hypothalamus is here. So it's responsible for eating, your circadian rhythm, which is going to be cortisol, which we'll talk about in a little bit. Sex drive, again, that's a whole feeding, and the 4 Fs for the hypothalamus. It was a meme in there somewhere. So remember that. Reticular formation. The reticular, whenever you think of that, think of consciousness and arousal. And then the last thing is our limbic system. That's our emotions, has reciprocal connections with reticular and the hypothalamus. We'll explain why in a minute with a graph, how they all interact with each other. So there's our hypothalamus, there's our pituitary gland, and they're all connected. You don't need to know all these little areas. Don't worry about it. We'll go through some of them in particular as we go through different topics, but otherwise, don't worry about it. Okay. So hypothalamus, obviously a lot of afferent inputs and efferents. I'm sorry, before I mentioned that anything leaving is, it's afferent. Visceral, somatic input is going to come here. And remember, hypothalamus is outside that blood-brain barrier. It's one of those circumventricular organs, so it can taste the blood, testing for osmolarity, and stuff like that, which we'll get through. The connections, obviously, it's going to go through reticular formation, controls peripheral autonomic nervous system, output to the endocrine system, and obviously our limbic system as well. So hypothalamus is very, very deeply embedded with a lot of parts of our body. Okay, food intake. How do we know when we're hungry or we're not hungry? So there's 2 areas of hypothalamus that are responsible for eating. Your ventromedial nucleus is our satiety center. What is satiety? Full. We feel full. And we have our lateral hypothalamic area, and that's our feeding center. That tells us that we're hungry. We need to eat some food. So there's a couple of other words. Orexigenic will stimulate feeding. So if you're seeing about neuropeptide Y or anything that ends with orexins, those are to stimulate feeding. Anorexigenic inhibits feeding. CRH will do it. Here's this cocaine and phenamine regulated transcript, CART system. For people who are on cocaine all the time, don't eat anything because they don't have any reason to eat. There's no drive to eat, and they get skinny. Before Ozempic, it was cocaine. I'm just kidding. So our food intake, short-term factors, hypoglycemia. So if your blood sugar drops, that's going to initiate that you're hungry, you need to eat, you need to replace that glucose. So you're going to get hungry. Also, the GI peptide hormone ghrelin also will tell you that you are hungry and you need to eat. So here we have fasting, we're not eating at all. Hypoglycemia, ghrelin will stimulate that feeding center of the brain so that we start to eat. Okay? Long-term factors is a hormone called leptin. Leptin, the concentration of leptin goes up with the amount of adipose tissue that you have. So over time, in a long-term response, leptin is supposed to tell the brain, hey, we have enough fat stores, stop eating. We have enough. Remember, fat is just a form of energy. It stores it, waiting to be used. And if we keep eating, we're not going to use that adipose tissue for energy. It's just going to stay there. So leptin is supposed to tell the brain, hey, we have enough fat stores, we're good. Leptin is also possibly one of the hormones that is, especially in young girls who are in gymnastics, who have no body fat, their periods don't start, they get delayed puberty and all that stuff, because they don't have enough fat stores. The brain doesn't think you have enough adipose tissue to support a viable pregnancy. And that's why their periods shut down. It's a fat, they don't have enough, remember, to make a baby requires a ton of energy. If you don't have enough fat, which is our reservoir of energy, the brain's like, hey, we can't support a viable pregnancy, let's not even have periods, let's just stop the menstrual cycle. And that's why they lose their menstruation. Has to do with leptin. Okay, another thing about food. There is a time period before you'll start feeling full. So once you start eating, in about 15 minutes, then you'll start feeling full again. That satiety center is being triggered, and you lose that hunger response. However, if you watch, I know in a couple weeks they have the hot dog eating contest for 4th of July. Well, they got to pound as much food as they can in 10 minutes, because if they go any longer, that brain is going to shut them off, you're not hungry, you do not get any more food, and they start throwing up. Because the body's we've had enough. So as long as they do it all in 10 minutes, and then they're fine. Well, a couple years ago, they had to go in overtime, I guess. So can you imagine eating 60 hot dogs and then waiting 10 minutes and have to do it again? No, so your feeding center can screw around with you. Okay, body temperature regulation via the hypothalamus. Remember, the hypothalamus is outside the blood-brain barrier, so it can sense certain chemicals in the blood and know what's going on. Don't worry about these things, the types of heat transfer. We don't really deal with that a whole lot. So regulation for our body temperature is very important, though. We have our peripheral thermoreceptors. Remember hot and cold, we learned that yesterday. So we have thermoreceptors in our skin, which will anticipate threats to our core body temp. That's that diver's reflex. You ever put your head in cold water? It's that makes you start breathing crazier. It's a diving response. Again, it's a threat to our core body temp. It stimulates a sympathetic response, and that's why you get happy afterwards and excited, because you activated your sympathetic system by dousing your face in cold water. We also have central thermoreceptors, and they're in the hypothalamus. That's always going to be monitoring what our core body temperature is. So if we look at temperature as a homeostatic variable, the temperature of our body, all they care about is our core. If you've ever been in cold weather, your fingertips get frostbite because we're trying to keep all the blood in the core to keep your core warm. Body doesn't care about your fingers, your toes, your nose. It'll just die off because it needs to keep the core warm. So effectors for body temp regulation, we have skin circulation, adrenergic sympathetic tone. By doing vasoconstriction, we minimize heat loss to cold. So we vasoconstrict parts of the body that don't need blood. That's why you lose blood in your fingertips with frostbite and all that things, because the blood's being shunted away. When we're hot, we vasodilate, and that allows us to sweat. And that sweating cools us off. Dogs, I don't think, can sweat, so they pant. And that gets the heat off through the tongue. But we can sweat, so we have it. I also read somewhere, I don't know if it's true or not, but people who were born in hotter environments like in the South, because babies don't have sweat glands. That's why you have to be very careful with temperature regulation with babies, because they can't sweat until they're older. But they think that people who live in southern hot environments have more sweat glands and sweat a lot to keep them cooler versus people who are born up north where it's not as hot. They don't need that adaptation. That's why some people like sweat like crazy, some don't. I don't know if it's true or not, but it's interesting. So that's skin circulation. We can alter our skin circulation depending if we're hot or we're cold. Metabolic rate, acutely in response to temp changes. Okay, low body temp will increase cell metabolism and increase our thyroid hormone. Thyroid hormone is a metabolic hormone. It speeds things up and gets you warm. Shivering also helps, but it's a short-term response. So when you first get cold, you start shivering. Shivering is a repeated muscle contraction. Muscle contraction, remember our energy source is our effectiveness of utilizing ATP is pretty weak. We lose a lot of it as heat. So we get warm when our muscles shiver to try and get us warm again. And obviously sweating is a very big response. And that's cholinergic post-ganglionic sympathetic innervation. Remember, this is ACH to the muscarinic receptor. This is the only one for sympathetic that is ACH, is your sweat glands. Everything else is at epinephrine, norepinephrine. So let's talk about fevers. Regulated increase in body temp in response to an infection or a disease. So the first thing that happens, we get cytokines that are released. They include pyrogens. What's pyro? Fire, heat. It's going to generate heat. They're going to make us have a fever. Okay, so they're released by our immune cells in response to an infection. Those cytokines are now floating along in the bloodstream. They're going to go through the hypothalamus, which is a circumventricular organ, and they can sense those cytokines. Third phase, we get prostaglandin formation by the OVLT, tells the hypothalamus to raise the set point. What is our normal set point for temperature? 98.6. That's what the hypothalamus sets. That's the homeostatic variable. But now we have an infection, so the hypothalamus is like, we need to raise our body temp to kill off any bacteria that's in our body. So now the hypothalamus is going to change the set point at this point from 98.6 to, let's say, 102. It can be, there's no set number, just get hot. That's all it really says. Now, because of these prostaglandin formations, if you give someone an NSAID like ibuprofen or Advil, how they work reducing your fever is they block the production of those prostaglandin E2, which then can never get to the hypothalamus to trigger a fever, okay, because we're blocking it. As the fever is generated, so your body temperature is now colder than what your set point is. You're going to feel chills, and you're going to start shivering because your body temp is less than what the hypothalamus wants it to be. So we're going to trigger a response to raise your temperature. When the fever breaks, that set point, because there's no more cytokines anymore, that set point goes back down to 98.6, but you've been having a fever, and your body temp is now 101. So now our core temp is higher than what we want. So what does our body do to cool off? Sweat. And that's why when you break a fever, you wake up in a pool of water, because your body sweats to cool yourself off back to the new set point. And that's how fevers work. Don't treat fevers unless they're like really uncomfortable, like 102, 103. 101, 100, just leave it alone. Don't give Tylenol, don't give NSAIDs, nothing. The fever is your body's natural response to kill off infection. It's like when you cook food, you need to a certain temperature so you can kill off all the bacteria. That's what we're trying to do in our body by raising our temperature to kill off the bacteria or the viruses. They can't survive in those hot temperatures. That's the theory. Okay, circadian rhythm is our cortisol. Peaks in the morning, that's what wakes us up in the morning. So if you're the person that always wakes up every morning at 6 o'clock, doesn't matter if it's the weekend or whatever, you just wake up at 6, it's your cortisol that's spiking that wakes you up. If you're under a lot of stress, your cortisol level is going to be rise and high all the time. If you ever wake up at like 3 in the morning, that's cortisol speaking to you. Growth hormone also peaks during sleep. So you know anyone who does a lot of training, muscle building, all that stuff, they sleep a lot because that's when they get growth hormone, and it allows for repair of the muscles. Both hormones come from the hypothalamus, or activation of the hypothalamus. Now, cortisol. Interesting thing about cortisol with breastfeeding. If you know in the future or know anyone who's breastfeeding, have them date and time when they pumped into the bottles. Why do you think the time matters of the bottle? If you pumped in the morning at 8 o'clock in the morning and you pumped, that's going to be loaded with cortisol. It's going to keep them awake. If you give that fluid, that breast milk, to the baby at 8 o'clock at night before bed, you're loading them up with cortisol. Are they going to sleep? No. So time it so you know these are morning bags. Give them in the morning because they have a lot of cortisol. Keep your kid awake. Okay, that's really it on circadian rhythm. It's just cortisol. And because we know cortisol rises in the morning, when we want to draw a cortisol level, when do you think we want to do it? In the morning. So cortisols are always done in the morning. So our reticular formation, again, this is our wakefulness, our arousal levels. Okay? Lesions here can result in loss of consciousness or even comas. And we have 4 major areas. First one is the serotonergic system. This is your sleep-wake. This is dealing with what neurotransmitter? Serotonin. Remember we talked about serotonin yesterday. It has a lot of role in arousal, keeping you awake. You have the noradrenergic system. Noradrenergic, what type of system are we stimulating? Sympathetic nervous system. So alarm center. Okay, new environmental stimuli is present. Okay, if you have an alarm go off on your phone and it wakes you up, your sympathetic system is going to be activated because you got woken up abruptly. Dopaminergic, this is obviously dealing with dopamine. We have 2 parts, the nigrostriatal, remember this is basal ganglia, this is all of our coordinated movements. And we have the mesocortical limbic, which is that reward system we talked about with drug abusers. Want that dopamine hit, and they ought to keep doing dangerous things to get that dopamine kick. And we also have the cholinergic, which is what? Acetylcholine, nicotinic receptors, it's your parasympathetic. And this cholinergic is very good for particular tasks and learning and memory. So these are different parts of the brain that have to deal with all of these different parts of systems. EEG is like an EKG, but it's for the brain. You put a bunch of different electrodes all over the scalp, and it's measuring brain activity. Only thing you got to know here, beta is when we're awake, alpha is a little bit wake, delta is sleep. And you can see here in the bottom, that is a seizure. You can see how that brain wave starts spiking like crazy. That's a seizure activity. Okay. So for sleep, obviously we have serotoninergic and noradrenergic systems are here, helpful in waking up, and very helpful in our awake cycle. Remember, these are arousal systems. Okay, so our sleep has our own distinct EEG patterns. We have non-rapid eye movement sleep, or non-REM. Parasympathetic is active. And stages 4 stages, and 3 or 4 are the most restful. So there's your delta wave right there, those nice calm waves when you're sleeping. REM sleep is dreaming sleep. So the brain is awake, but the body is paralyzed. You remember those sleep paralysis? Kind of like that, whether you're awake or not. So those are different phases of sleep. So just know that REM is dreaming sleep, and know that what waves are sleeping waves. Okay, the limbic system. Now we get to memory, which hopefully all of you are hoping works very well. You got an exam on Friday. So obviously we're going to be a lot of crosstalk with different structures within the brain. What time is it? 1:16. Okay. We have the cingulate cortex, which is up here. Sensation of emotions are perceived here. So whatever you perceive in your environment, the cingulate cortex is the one that recognizes it. The hippocampus, short-term to long-term memory. Okay, make sure that hippocampus is working so it all sticks. Okay. The amygdala, strong emotions, fear and aggression are here, linking emotions with memories. We're going to talk about fear and anxiety in a second. Fears are learned things. There's only two things that we are born with for fears. Two fears that we're innately born with instinctively. What are they? Dark, or not really, I think it's not dark. What else is it? Heights is one. Sound. Someone said sound. Loud noises. All your other fears that you've gained in your 25, whatever, how old you are all learned things that you've been exposed to, and your body has analyzed that these are bad experiences. So that when they happen again, your brain automatically thinks this is a bad experience. I need to inhibit, or I need to start my sympathetic response because this is a stressful environment. So we'll see how all this kind of works together. Let's take a break now. Before we talk about this, come back. What time is it now? 1:17. Okay, come back at 1:25. Okay, let's get started so we can finish up. We don't have that much left, for neuro anyway. Okay, so we have a little diagram here. I want us to start in this area first. Experience of emotions. Remember, the experience of emotions is handled by the cingulate cortex. It interacts with the prefrontal cortex, the frontal lobe of the brain. That is our decision making. So let's say someone punches you. Your instinct may be to punch back. But your frontal lobe will say, you know what? No, it's not worth it. Don't do it. That make sense? So the frontal lobe is there like, okay, fine. That's why young kids don't have a very developed frontal lobe and they make stupid mistakes until they get older. So even through college, that frontal lobe takes a while to fully develop, so your decision making will suffer until it does. So anyway, so prefrontal cortex, that emotion, that experience, that stimulus that you're getting also goes to the hippocampus for memory processing. Is this I guess that movie, what was the movie with all the different characters were inside someone's brain, those core memories? Yeah, Inside Out. It's like that. You have a core memory. If it's strong enough, you're going to remember it. The hippocampus is going to remember it because it was a strong enough of emotion, it's worth to remember. Hippocampus is then going to talk to the hypothalamus. What's the hypothalamus responsible for? What's it going to do? Mediates the response. Is this a stressful environment? Do we need to kick in our sympathetic system? If so, the hypothalamus needs to know because it's going to control it and get our sympathetic system involved. Obviously, it's going to go to the brainstem and the spinal cord to exhibit that sympathetic nervous system response. Expression of emotions goes on here. How are you expressing yourself? So the experience, so if you get into you haven't had an exam yet in grad school, your first one's on Friday, you have no idea what to expect. If Friday is a good experience, then you're going to have a good, favorable thinking of exams going forward because you had a great experience the first time, you're like, okay, that wasn't so bad, I can do the next one. But if you're like utterly destroyed the first one, which none of you will be, but maybe you'll be scared. Now the next exam, you're like freaking out. Oh, I just had another exam. You see how your emotions and your anxiety and your fears get developed? That's kind of why this is all going on. I'm not going to go into great detail about this one, just to understand what the parts do, the cingulate cortex, what that's responsible for, hypothalamus, and the hippocampus. Here's your fear and anxiety. So again, stress response is when you perceive as threatening. Your perception, okay? What I may feel threatened by, you may not feel threatened by. We will have different responses to the same stimulus. Just like the exam on Friday, you are all receiving the same exact stimulus, but people react differently to exams. So again, our amygdala, mediating our fear response. Our higher cortical areas integrate the information with learned experiences. So again, like touching a hot stove, you do it once, you won't do it again because you've learned from your previous experience with a hot stove that if I touch it, I'm going to hurt myself. So then you'll be cautious from here on out, not doing stupid things. So you got to learn. And they produce it into the amygdala. Amygdala will stimulate hypothalamus to activate fight or flight. Hippocampus will provide negative feedback to limit the stress response. So it kind of blunts it for us, keeps it under control so we don't have a total freak out. Aggression is an emotion related to fear. That's why people get scared, they will get aggressive. They're very close to the same part of the brain together, so they always go together. They kind of link. And again, normally suppressed by your frontal cortex. So if you're scared or you're going to fight, again, your frontal cortex will say, no, it's not worth it. Like I said the other day, you can walk by an old person on the stairs and push them if you want, but your frontal cortex will say, no, don't do that. It's not a smart thing to do. Language and speech. We have to be able to hear what I'm saying and answer appropriately for a question. So comprehension of language and speak is a very sophisticated action. You guys ever hear of the stoned ape theory? So basically, the reason why we know how to talk is because thousands of years ago, whatever, 100,000, millions of years ago, whatever our ancestors were, we're following animals. And they followed animals how? Through their dung, poop left behind. What grows in poop? Mushrooms. So they were getting high, eating all these mushrooms. And they needed a way that altered the temporal lobes of the brain so that they can now process thought. Because they were tripping on colors and needed a way to express what they were doing or seeing, and that's how we started speech, from mushrooms. Speech is dominated by the left hemisphere. So your left hemisphere controls the majority of your speech and your hearing understanding. We have two main areas, Broca's and Wernicke's. Broca's is in the frontal lobe and controls the mouth. So this is a motor function. And also if you look where Broca's area is right near this primary motor cortex. This is motor. It's in the precentral gyrus. What is in the postcentral gyrus? Sensory. And that map of the brain that mapped out all the different territories of the body is called a what? Homunculus. We have a sensory homunculus and we have a motor homunculus. Relatively the same parts of the brain, it does the same things. Wernicke's area is in the temporal lobe near the auditory cortex. This is mainly for like comprehension. Are you understanding what I'm talking to you about? It's in your temporal lobe. Temporal lobe is spatial recognition, thought processes, hearing things. Remember we talked about Einstein had an extra lobe in his temporal region, more thought. This is where comprehension comes into play. I think it's in this next slide. Yeah, so you don't have to know this, but just so you know, when someone has a stroke that causes them to have speech problems, if they understand what you're saying, they just can't articulate the words because they have a motor problem, that's a Broca. That's the Broca's territories where that stroke occurred. Ask them a question, how are you doing today? Okay. That's all they can say because they can't get any more words out, or someone else will help speak for them. With Wernicke's area, it's comprehension. They can speak just fine because the motor part of their mouth is working fine. But the Wernicke's is the comprehension. So I ask, how are you doing today? They'll say, oh, I was on a boat and it was sunny and we went to eat and blah, blah, blah. Like nothing related to whatever question you ask them. They're just talking in tangents and they don't understand what they're saying either. They don't comprehend because that part of the brain is damaged. That's the Wernicke's area. Okay, we're done. Okay, let me go to the other section here. Hang on. Do a quick immunity. We're not spending a lot of time. Okay. So we're going to talk about our defense mechanisms, B cells, T cells, and immunity, real fast. This is the only meme I actually created. All the other ones I just steal offline. This is the one. If you get it, it's funny. If you don't, watch Dave Chappelle. It's funny. Okay, our defense mechanisms. We have to be able to protect ourselves from the outside environment. Okay, they're called pathogens from the outside coming in. We have two different types. We have innate, which is what we're born with, and we have adaptive, which comes from learned from exposures. So vaccines is a adaptive immunity. If you breastfeed, it's adaptive immunity because you're giving IgA from the breast milk to the infant. It's adaptive immunity. You're giving them the antibodies. Cells, they all come from the same precursors inside the bone. If it goes to the thymus gland, it becomes a T lymphocyte. If those things stayed in the bone and it developed into a B cell because it comes from the bone. So B cell comes from the bone, T cells mature in the thymus gland. Easy to remember those two things. Okay. So innate immunity, things that we're born with. We have external. Remember, there's anything that can get in from the environment, we have to be able to protect ourselves. So our skin technically is the largest organ we have with our entire body, and it's protective. It keeps things out. Digestive tract, respiratory tract, and GU, those are all other areas and ways for things from the outside environment to get in. So we have to have some protection there as well. Digestive tract, high acidity of the stomach, kills anything that gets in the stomach. Respiratory tract, your mucus traps all those pathogens in the mucus, and then you cough it out. And if it's like yellow or gunky, you know you got a lot of crap in there, you were sick because you have all this stuff you're coughing out. Genitourinary tract, acidity of the urine, supposed to help prevent UTIs and so forth. Internal, these are stuff within our cells or different structures that provide immune function. Phagocytic cells are basically just floating around in our bloodstream, scavengers eating up different things. Interferons, anytime you see the word interferon, just think of viruses. They always go together. Interferons work with viruses. We have complement proteins, endogenous, natural killer cells. These are transplanted tissue cells. Mast cells release histamine. What does histamine do? Makes you leak fluids, so you start getting snot running down your nose. So when you think of mast cell, think histamine. It causes swelling to happen in your joints when you get an injury. Okay, histamine causes the capillaries to become very leaky. They get in there. Again, we went through taking an antihistamine. This makes it so you don't have a runny nose. It stops the leaky. Oops, I don't want to do that. Okay, so innate immunity again. With phagocytosis, neutrophils are the first ones to come. So we're infection, responsible for bacterial and viral, so your neutrophils. Then your monocytes show up. And you also have our innate organ-specific ones. Liver has filtering cells. Your liver is perfectly functional. You don't need to put those little stickers on your bottom of your feet. They're not going to do anything. Your liver is perfectly normal, can clean everything out. And again, those phagocytic cells in their location, Kupffer cells are in the liver, alveolar macrophages in the lungs. Remember we talked about microglia already? Those are the immune system in the nervous system, immunity in the nervous system. And then here's just examples of the slides of what they look like. Here are the interferons. Remember, these are always doing with antivirals. So just remember, interferons have to do with viral infections. Okay, adaptive immunity, things that we're getting. Okay, we have to defend against specific pathogens. Okay, we have to know what we're fighting against. Basically, immunity, think of it as a blueprint. It's a method of defeating an enemy. And they just give us a blueprint, and when we get exposed to that pathogen, our body already knows the plan, and we can produce antibodies. So it's mediated by the antigen, which is the pathogen, and antibody formation. So B lymphocytes, they come right from that bone marrow we talked about. Bacterial, some viral, but mainly bacterial infections for those B lymphocytes. These are the ones that are responsible for making antibodies. Only the B lymphocytes make antibodies, and they are specific to a pathogen. So they know how to fight it off. We have different infections, we have to fight them off differently. Very short lifespan. It's also called humoral immunity, from the humerus, the bone, humeral, bone, same thing. Or antibody-mediated immunity, because it's antibodies that are fighting off the infections. So, if you look at this picture here, okay, we have a developing B cell at the top. Then you'll see it has different B cells, and they have different receptors with different colors, which means they are specific for certain pathogens. Only certain things will fit in those slots. If that pathogen is in your system already and it's floating around, it's going to bind to that B lymphocyte. And when it binds, then it starts replicating and producing antibodies. And all those things at the bottom are all the antibodies to fight that specific pathogen. Okay, it's all specific. So that's what the B cells do. Now, how do the B cells know what to do? They get help from the T lymphocytes. So the T lymphocytes, remember, it goes to the thymus, and they become T lymphocytes. T lymphocytes attack host cells that become infected with a virus or fungus. Transplanted human cells, so whenever you get a transplant, you have to go on high-dose steroids to knock out your immune system. Because if you don't, those killer T cells are going to go to that transplanted organ and kill it, because it sees it as a foreign body. Okay, so that sometimes that can happen as well. So a lot of people with transplants will go on those high medications. Cancer cells will do it. T lymphocytes don't produce antibodies. It's called cell-mediated immunity. So T cells are cell-mediated. What does that mean? I think it's the next slide. We have two different types. Okay, this is a comparison, just like a summary slide. Read that on your own. Do I have it here, or is it down more? It might be down more. Okay, we'll get to it. We're kind of explaining it right now. Okay, so our lymph glands, we have our lymphoid organs. You guys, for PAs, we're already palpating all the lymph nodes. Obviously, lymph nodes makes all your lymphocytes. So when you are sick, they get bigger because they have to produce more and more cells, so they pop. So when you're sick with a bacterial infection mainly, and you start feeling for your lymph nodes, they're going to be big because they're fighting off an infection. They have to get bigger to make more and more cells. They also have other ones, the thymus gland, which we know spleen and lymph nodes can also store and make stuff as well. So your spleen is there as well. Secondary organs, spleen, thymus, bone marrow, lymph, and so forth. Tonsils are here and whatnot. So these are all secondary lymphoid organs. Don't go into great details with these things. Again, just know that they're there. And our lymphatic system helps prevent edema. Okay, it just takes excess fluid out of our blood system, out of the interstitial space, and puts it in the lymphatic system, which then recirculates in our body and goes somewhere else. They think that lymphatic blockages are causing some cancers to form because cancers can get out and we drain it through the lymph system, but if your lymph system is blocked, cancer cells have nowhere to go and they start accumulating, and then they can embed somewhere and cause cancer. Okay, so B lymphocytes. Big thing with this one, they have to be exposed to the specific antigen, then undergo cell divisions, and the main goal, produce antibodies. That's the gist of what you got to know from this slide. They get a specific antigen. So here is a helper T cell. The helper T cell, all it does, floats around the bloodstream. If it sees a pathogen, it grabs onto it, and then it presents the pathogen to the B lymphocyte. So the helper T cell brings the pathogen to the B lymphocyte. So now the B lymphocyte knows what we're battling against. Because we've been exposed prior to this, B lymphocytes, they're memory cells. They know what the pathogen is. They know how to defeat it. So they produce all the antibodies to kill off whatever infection is going on. So you need the helper T cells to do that. What disease kills off all the helper cells? HIV/AIDS. So what happens, they don't die from AIDS, they die from pneumonia or some other secondary infection because their immune system can't work. They can't kill it off. They don't have the helper T cells to present any of these simple pathogens to the B cells to fight it off because the helper T cells are gone. And if you, it's not in here, but we'll get to it later on. The helper T cells has the CD4 receptor. So if you ever hear CD4 with HIV/AIDS, CD8 is on the killer T cells. So the proportions of what happens alters your immune system. So this is what happens when our body gets exposed to a pathogen for the very, very first time. So you get your Hep B series, for example, you get 3 of those. So for Hep B. So the first time you get the Hep B vaccine, first injection, you get a primary response. That's just our body. Okay, we have an infection, we have to do something about it, but we haven't really memorized what this pathogen is yet. This is our first time being exposed to it. So we get a small little response. Then some time goes on, and now you need a booster shot or the second series. When you get the second one, now we have a bigger response because this is the second time we've seen this pathogen. Our memory B cells know what to do, and they deliver the response to kill off or fight whatever is going on. Which is why sometimes when especially with that COVID vaccine, if you got the second one, some people got really sick for that day after the second one. That means that it did its job because you got exposed to the virus again, your body knew what to do to fight off and kill it. So it elicits every secondary response when you got that second injection. That response can cause fevers, so some people feel like garbage for a day after getting the second one. But again, that means it worked. That means it did its job. Your body knows what to do. Problems come into play when you get this secondary response is very hyper responsive. That's asthma. That's if you get stung by a bee and your hand swells up really bad. That's a secondary hypersensitivity. People eat peanuts and get anaphylaxis, they can't breathe. That's a secondary response because they've already been exposed to it. Now they get it again, and that's why if you keep repeating these exposures, they get worse every time. So people like peanut allergies. The more times they eat peanuts every successive time, that response can get worse and worse because this response just keeps getting worse and worse with those types of reactions. So these are the types of immunoglobulins. These are the antibodies. There's only 5 of them. Okay. IgG increased after immunization and secreted during a secondary response. So you guys were coming into school this year, you probably needed some sort of titers to see where your levels are for your vaccinations. They were looking at IgG because that IgG means you've been vaccinated and you should have those antibodies floating around. If you don't see the IgG for that bacteria or that type of antibody, then we know you're not covered. You need to get another injection. IgA, external secretions. This is in your saliva and breast milk. This is the way antibodies go from the mother to the baby, IgA, through the breast milk. Saliva in humans, we've kind of lost this trait, but in animals, that's why animals lick their wounds, because they got IgA in the saliva, and they're giving themselves antibiotics, essentially, to the wounds. That's why they lick their wounds. Okay? We've lost it because we take care of ourselves with medicine now. IgE, always associate IgE with allergies. So if you have constant allergies all the time, your IgE will be elevated because of the allergies. IgM, this just means that you've secreted during that primary response. So that first time you got the injection or the vaccine, you're going to produce IgM antibodies because it's your first time exposure. The IgG is your secondary constant response. That's all you got to know for these antibodies. Don't go crazy knowing, just know what each one, IgD we don't really know what it does, but just know it's unknown. As long as you know the other four, you're good. Okay, our T lymphocytes, we have our killer cells, also known as CD8, and CD8 just refers to the type of receptor. Okay, they destroy cells that are infected with viruses or fungus or cancer cells even. So your killer T cells, CD8, are very good at, obviously, killing things. Okay? So remember, T cells are cell-mediated, meaning the cells have to touch. Remember, B cells, B lymphocytes, is antibody-mediated. It just produces antibodies. And the antibodies do whatever it's got to do to kill the pathogens. But T cells, it's cell-mediated. They have to touch. So this is touching right here to kill off that cell that's infected. It grabs onto it, injects its contents, and kills it off. Helper T cells have CD4 as the receptor. And again, it makes the B lymphocytes work better because the helper presents the antigen to the B lymphocyte. So the B lymphocyte, again, knows what pathogen is floating around and knows how to take care of it. So here's another way of looking at it on how they work. Again, you don't have to go into detail all these things. The helper cell is also known as an antigen presenting cell because it presents the antigen to the B lymphocyte. And then your killer T cells just kill the target cell. Yes?
When it says improvability of B lymphocytes to become plasma cells, is that just the maturation of B?
To make antibodies. Okay. Remember that it has to have the binding of the antigen to the B cell first. Then it knows what it is, and then it makes antibodies.
So that's a plasma cell?
Yep. So the T cell brings it to the B cell to make it. And again, here's another way of looking at it with regards to antigen presenting cells. This is your killer T cell. It's going to kill that. So you get destruction. Here are your helper T cells. Here, that foreign antigen is right there in the middle. It's presenting it to the macrophage or the B cell, telling it what's going on. And here's the B cell, I'm sorry. Presents it, and then it starts making antibodies to dump off. So antigens in summary, we get the stem cell. They can either become a B lymphocyte or a T lymphocyte. Depends on where they mature. The T lymphocyte helper T cell helps the B lymphocyte to make plasma cells, and finally your antibodies. Just remember the T cell, the killer cell, just directly kills it. Killer cell directly kills the infected cell. The helper T cell brings the antigen to the B cell to make antibodies. That's the biggest takeaway from all that. Other types of active and passive immunity, we kind of talked about a little bit about it. Active immunity, this is when you start getting exposures to vaccines. Again, you have your initial exposure, primary response, get another exposure, and you get a larger response. Okay. And that secondary response, maximum antibody production in less time. So we're faster to get those antibodies developed, faster to heal ourselves. Okay. So developing of that secondary response provides active immunity. So once you have that secondary response, then we know we have active immunity. Again, requires prior exposure. We have to have been exposed to something in order to make those memory cells to make all the antibodies. Also used to make vaccines, and the vaccines aren't virulent, so they can't really cause diseases. All vaccines do stimulate that primary response without making you sick. So you can use a killed virus like the polio, A live virus, which has been attenuated, so it's not as virulent, it's not going to cause an infection. Viruses, they can't replicate or anything, so they're kind of just dead, but it just gives us the blueprint that we know if we get this type of structure again, we know what to do with it. And genetically engineered recombinant viruses, and that's your Hep B viruses like that. You don't have to know the details of this, just understand how it works. Passive immunity is giving antibodies from one individual to another. This is breast milk. The baby doesn't make IgA on its own, but the mother can, and it's in the breast milk. Mother to fetus also, while the fetus is developing, antibodies do get into them as well from the mother. And you have artificially with antidotes, snake antivenom. Snake venom, rabies are very, very rare things. We really shouldn't see them very much. So you shouldn't have an immunity to those things because you don't need it. So if you get bit by a dog that you think is rabid or whatever, bit by a snake, they just give you the antibody. So the antivenom is the antibody to the snake bite. And they just give it to you, and it takes care of the infection for you. So that's what that is referring to. But again, it's passive because you're not creating the antibodies yourself. You're just giving them from somewhere else, from the mother or from an antidote. And this is just a good summary slide to review. And just, again, generalized, that's it. Just general information about this stuff. Don't go crazy, detailed. Just understand what the B lymphocyte, where it comes from, what does it do. Understand the different antibodies. And tomorrow will be review. Okay? Remember, PA, you're upstairs, 314.